Hi there. My name is Dr. Hermine Creger. I am one of the faculty at Walden University, and I want to help you with a quick clinical consult on a child that presents with a rash and respiratory symptoms. So our fella is a 4-year-old unvaccinated boy that presents with his mother to your office with a 5-day history of cough, rhinorrhea, red watery eyes, and his mom also reports a raised rash that started on his face and spread to his neck, chest, back, arms, and legs. The rash is described as small spots that have coalesced to large blotches, particularly over the chest, back, and abdomen. He has missed 5 days of school due to fever. On exam, he appears ill, but he's not in distress. His temperature is 102.4. He has injected conjunctiva, small white papular rash with white centers on his buccal mucosa in the mouth, and a blanching erythematous raised rash on his chest, abdomen, and back. His lungs has crackles on the right lower lobe. You did some blood work on him, and his CBC shows a white blood cell of 3,100. Normal is 4,500. Hemoglobin of 15, that's normal. And platelets of 102,000. Normal is 150. So let's look at what information we have. You have an onset of acute fever, malaise, cough, rhinorrhea, and conjunctivitis. You have an erythematous raised rash sparing the palms and soles. I always tell my students, make sure when you look at a rash to include the palms, the soles, and the mouth. He has a lung exam that has right lower lobe rails. He has a medical history of being under-vaccinated. He has leukopenia, and he has thrombocytopenia. So, let's look at our list of differential diagnoses. Well, off the bat, looks like a simple upper respiratory viral infection. He has all the symptoms of a respiratory infection: cough, rhinorrhea, conjunctivitis, and he also has leukopenia and thrombocytopenia, which is not uncommon in viral illness. Our next one is a bacterial infection. Well, that is very possible. He has a fever that lasted for more than 5 days, and but he does not have a raised white blood cell, even though he has a lung exams with right lower lobe rails. So a bacterial infection, less likely. Then he can have a drug reaction. Mom didn't give him any drugs or any medications that she reported, less likely. Let's look at Kawasaki disease. So Kawasaki disease is a bacterial infection associated with vasculitis 2, usually has a temperature of 5 days. The rash is usually bright red, but it includes the palms and the feet, and also inside the mouth, it's bright red. Possibility, because we have fever, we have the rash, but clearly very different, so low probability that it is Kawasaki. Pediatric rubella, that's the common old 4-day measles. So rubella has a low-grade fever. We have a high-grade fever in our child, and it's only 4 days, the entire illness usually. But don't put it totally away, because the rash also starts with the ears and the neck, but it's usually red, pinkish, and not coalesced like in other rashes. Then we have measles. Measles usually presents with a high fever that lasts more than 5 days. You have a bright red rash that starts in the neck, and you have white spots inside of the mouth. That sounds possible. Measles also can spread very easily, as you know. Then there is scarlet fever. So scarlet fever is a bacterial infection that's usually caused by streptococcus and also has a rash, but this rash is sandpaper-like, and additionally the children will have swollen or painful lymph nodes. So which one do you think is your most likely diagnosis for this child? Measles. Your diagnosis is made by high suspicion, unvaccinated, fever for more than 5 days, and a rash that started from the head and moved down to the body. So the US has made great progress in containing the outbreak of measles, but I thought it was important to review this with you because measles is making a comeback. So let's look at the usual course of the illness, which is the left side of our picture here, and the progression if it's undiagnosed, or the symptoms that can be fatal for these children. So on the left, measles, after the infection occurs, which is a airborne infection, usually or virus, that usually starts, and then for 7 to 14 days later, only 7 to 14 days later, the child will suddenly start with a high-grade fever that usually lasts more than 4 or 5 days, cough, runny nose, and red watery eyes, conjunctivitis. So that sounds like a simple cold, and that is the problem, because most parents will assume that their child has a simple upper respiratory and not always bring them in to evaluate them. And even if they bring them in to evaluate, you will likely say, looks like a viral infection to me. So we will walk through how to handle this in the clinic, but for now, let's look at how it progressed. 2 to 3 days after the start of the respiratory symptoms, you will see tiny white spots, we call them Koplik spots, that appear on the inside of the mouth. And then days after that, now we get the well-known rash associated with the virus of measles, and usually it's cephalocaudal, which means it moves from the head, starts behind the ears, progress to the neck, the chest, and then the rest of the body, but sparing the palms of the hands. Usually after a few days the fever subsides, the rash fades, and the child does well. However, on the right of the slide, we have some cases where there can be severe consequences. Most concerning is encephalitis. 1 in 1,000 people will experience measles encephalitis, where the virus actually attacks the membrane of the brain, and that may result in convulsions, and if left unobserved or untreated, may render the child with permanent mental impairment or even deafness. Ear infections. 1 in 10 children with measles will get an ear infection, which can cause permanent hearing loss. They develop pneumonia. 1 in 20 children will get pneumonia, which often is associated or cause of death for children with measles because they develop sepsis. And then finally, worst case scenario, for every 1,000 children who gets measles, 1 or 2 will die from it, sadly. So how do we diagnose measles? So there are different lab values that you can use to diagnose measles. I always tell my students to ask your facility or institute or office where you work or where you send your labs out, which lab is available. We have a serum test for measles IgM. You can do a nasal or a throat swab for a viral culture. You can do a urine sample for a viral culture. We've got the RT-PCR for measles RNA, which is also used for flu, but that is very seldom available outside of teaching institutes, I must say. And then, of course, you have your CBC, where you will have low platelets and low white blood cells, which will suggest a viral presence, whereas elevated white blood cell may suggest bacterial presence. Treatment. Treatment is real simple: supportive care and infection control. So these children are fussy, they don't feel good, they're cachetic, so they are often dehydrated when you see them when they're really sick, and may have electrolyte changes. So it's very important to make sure these children remain and stay hydrated. You will treat your fever with Tylenol, remember no aspirin. You will treat secondary infections like pneumonia, otitis media, cellulitis, or conjunctivitis. Because remember, those are bacterial, so you need an antibiotic for that, whereas your illness is really viral, and we don't treat viral illness with an antibiotic. Then studies have found that vitamin A is usually low in children that present with measles, so they suggest supplementing vitamin A for 2 days. Very important, report cases to the health department. And then lastly, educate and counsel on quarantine and vaccinations. So let's look at our clinical polls. Measles is very serious. It is an airborne viral infection that is more common in our times due to under-vaccination, increased migration, and increased global travel. Incubation is 6 to 21 days, and patients is contagious for 5 days before the rash start and up to 4 days afterwards. Clinical suspicion and a good history will clinch your diagnosis. Negative lab values does not rule out measles, as children can still be ill during the incubation, and you didn't know that. The most serious complication of measles are acute disseminated encephalopathy and subacute sclerosing panencephalitis, both resulting in neurological symptoms or delay in development and can be fatal. MMR is a live attenuated virus. This vaccination should be given to all children as recommended. However, immune-suppressed patients should only take the medication or vaccination if they are advised and they consulted with a full medical team. These are children that are being treated for lupus or rheumatoid arthritis or are on immune suppression medications. So let's see how we approach measles in the clinic. First of all, confirm the vaccination status on all your pediatric patients. Flag those patients' charts that are not vaccinated. That way, if they come in with a simple complaint of persistent upper respiratory, you will immediately have your radar up because you know that they are not vaccinated. Next, since testing for measles are inconclusive during the prodromal stage, any child with or without vaccinations with respiratory symptoms, cough, conjunctivitis, or rash should be screened for measles. And again, I say screened. I did not say tested. Big difference. So screened means you're going to ask them if they are vaccinated. You're going to ask them if they've been around somebody that had a rash or measles. And you're going to make sure that you educate the patient to ask the parents, are you suspicious that they have measles? Because they're not always forthcoming to admit that there is a family member that is not vaccinated for measles and they suspect measles. Finally, measles vaccinations does not guarantee immunity, but it reduces the risk up to 99%. Finally, counsel all parents on the values of vaccinations and provide electronic or handwritten educational material. Here is my toolbox slide. I tell my students to take a snapshot of this and put it somewhere where it's easily available. It is just a short abbreviation of what you expect on what day as the child progresses through this measles. Finally, there is a lot of discussion and opinions about vaccinations. There is a lot of fear about vaccinations, particularly if they are known to be a live vaccination. So the easy way to do this is I provide this slide or this information to my parents to tell them that yes, it is a live virus, but it's a weakened measles virus, just enough to trigger the immune response, which will then put that response and that recognition into the cell's memory bank. And if it ever runs across that particular virus again, it will immediately recognize it and mount the appropriate response. Then I think it's important to remember MMRs are given at 12 to 15 months and the second dose at 46 years. Remember, our most vulnerable ones are our newborns through 1 year old because they have no immunity against vaccinations, not by choice, but because we wait till 12 to 15 months for our first MMR. Right, let's finish up with a quick knowledge check. The advice on containing and the spread of virus is hand hygiene, wearing a mask covering the mouth and nose, and notifying the health department. How long does the pediatrician recommend the child and family to quarantine at home? Until the rash is entirely resolved, 7 days following the onset of the rash, 4 days following the onset of the rash, no isolation is needed, or 7 days following the onset of the fever. The answer is 4 days following the onset of the rash. Remember, measles are only diagnosed when the hallmark rash appears after they've had this fever and upper respiratory symptom for up to 7 to 14 days. So isolation, number 4. 4 days, that is C. During which phase is Koplik spots visible in the mouth? Now remember, the Koplik spots are the white spots with a dark center that's in the buccal mucosa. 1 day before the onset of the rash, 1 day after the onset of the rash, same time as the onset of the rash, or same day as the fever start. The answer is B. I apologize. The answer is A. 1 day before the onset of the rash. Remember, you are an advocate not only for your patient, but also for your community. One vaccinated person can infect 9 other unvaccinated people. Thank you very much for your time. I hope you enjoyed this quick presentation, and have a good day.